Hello, I'm Karen Ashforth. I'm a lymphedema therapist practicing at a hospital-based outpatient lymphedema clinic in Stockton, California. In this poster, I would like to discuss how swelling and fibrosis can impact venous disease and venous surgery results. In my practice, I have treated a number of patients post-procedure who have experienced increasing swelling and fibrosis. I'd like to discuss the types of soft tissue fibrosis that I often see with my venous patients. Most common is lymphostatic fibrosis, which is of chronic swelling and presents first as soft, fatty tissue that can grow into lobules and becomes harder over time. Lipodermatosclerosis is the hard band of fibrosis that appears around the ankles of many venous patients and creates the characteristic inverted champagne bottle presentation in the lower leg. Patients who have had lower leg cellulitis frequently develop fibrosis in the areas that were infected, which obliterates circulation and encourages future infections. Atrophy blanche is a process that affects blood vessels and leaves hypopigmented scarring. There are a number of types of dermal fibrosis, including hyperkeratosis and papillomas. The goal of lymphedema treatment is to improve venous and lymphatic circulation and address swelling with decongestion, elevation, compression, exercise, and skin care. To illustrate this treatment, I'm presenting a case study. This patient was interesting because 18 months prior to referral to me, she had a procedure on her right leg. Her left leg was asymptomatic at that time. She was used to using stockings and elevation, but had a job that involved constant standing. She was referred to me because both her legs had significant swelling, and she was to undergo ablation on her previously unaffected leg. To summarize lymphedema treatment and results, after 1 month, she showed a significant reduction in both legs. She adhered to her conservative home treatment of compression, elevation, and exercise. She then had an ablation on her left leg and continued her home program, returning to my clinic 2 weeks later. Without clinical decongestive treatment, her right leg had regressed back to baseline, but her left leg showed further reduction as a result of the surgery. We did treatment another 2 weeks and re-achieved the previous reduction on her right leg. Her left leg did not make further progress. She then started using pneumatic compression at home, and when I reassessed her 2 weeks later, she showed a further improvement in swelling of both legs. She also demonstrated a significant softening of lymphostatic and cellulitis fibrosis. Breaking news, I followed up with her recently at 6 months. She continued her conservative and home pneumatic programs and maintained the gains in areas of swelling and fibrosis.